through health and wellbeing scrutiny. Where do we start? We've got the Ambulance Trust. We've got a fair few here. We've got Foundation, NHS Foundation, and I'd also like to welcome Claire Jackson at the back, who's sitting in for Derry Nugent from Health Watch. Now then, we'll introduce, everyone will get introduced as we go on, so without further ado, apologies for absence. Right, okay, Catherine Seymour. So the Berwick bunch is not quite all here. Minutes, anything from the minutes of the previous meeting?
Move acceptance, Chair.
I say that. Disclosure of members' interest. I see none. Right, item 4, Northumbria Healthcare NHS Foundation Trust Quality Accounts. And I've got Alistair Blair, who we know, and Rachel Carter. The floor is yours.
Thank you very much, Chair. Put the mic on for everybody. This is very much a formal presentation on quality accounts, as you'll see. We'll just go through it. I'll start and then hand over to Rachel. So the first slide is really what we've termed big signals, which is what we're using basically with our own staff as well as the public around the biggest priorities, particularly supporting patients and our people, particularly our staff. A big emphasis on growing our own. We've got a Health and Care Academy opening in the next few months with really an aim to be able to train healthcares and other members of the clinical team into full-grown nurses. So the aim being very much that we can support and grow our own. Continuing what I know at times the NHS performance doesn't seem great. We are probably one of the strongest performing trusts in the country, certainly amongst acute trusts, and we want to continue that for our own pride, but more importantly for the patients we serve. Supporting economic growth, which is particularly important because we are a very significant employer in the area. Continuous focus on innovation. A lot around digital, particularly on patient records. There's some estate redevelopments. I've mentioned the Health and Care Academy, and obviously Berwick is now, there's a lot of work going on there at the site with the new community hospital and continue to work in partnership, particularly with colleagues like NIAS. So just quickly talking about service pressures. Unlike the rest of the North East, we've probably seen more increase in attendances to NSEC in particular, and also the urgent treatment centres, higher than the rest of the North East. So we've seen a consistently high number of attends throughout the year. We've had to open additional bed capacity, particularly during periods of surge, and that has not been the expense of surgical capacity. Normally you would expand into surgical beds. We've tried to avoid that so that we can continue with the surgery, and that helps for the waiting list. It's fair to say there has been both consultant and junior doctor strikes, which teams have worked really well with. We've tried to avoid cancelling wherever possible operations, but it has had quite a big impact on resilience. We have seen improvements in the under 62-day cancer waiting times. Urology in particular continues to be one of our biggest concerns about that, and we're doing a lot of joint work with Newcastle because most of our consultants also work in Newcastle, and there's a continuing interplay really around urological services across the North East where the cancer waiting times are not as good as they should be. And then we've probably got some of the shortest waiting lists in the country, but anybody who's a long waiter is a wait too long, and we've got a lot of work going on, particularly at those who are waiting beyond the 18-week constitutional rights, and particularly 52 weeks, where there's a real focus on reducing anybody who's waiting a year for any procedure. Some of those it's because of complications, some of it's because they've actually had health reasons that they've had to have procedures delayed, but we want to make sure that's zero. Handing over to Rachel.
So hi everybody, my name's Rachel Carter and I'm the Director of Patient Safety at Northumbria Healthcare. So I think the quality account gives us an opportunity to look back at what we've achieved and also where we need to focus more clearly in the coming year. So we've got our look back in terms of safety, quality and improvement priorities for 23-24, and also the focus for next year as well included within this presentation. So a look back over the last year, I think it's fair to say it's been variable in terms of how we've performed against these objectives. I think it's also fair to say that we always put ourselves under a great deal of challenge in terms of when we are defining these, so that they are not easy things to achieve. So this was the list, the 7 things that we chose to look at for 23-24, and I'll go through those in a little bit more detail for you. So we haven't got Q4 data finalised as yet, so this is up to the end of Q3. As soon as we have the end of Q4 data validated, and some of it isn't even in yet, we can reissue you with those figures to see where we ended up. It's probably fair to say that improving flow around ambulance handover delays probably won't change in terms of it won't go to green. We haven't achieved what we set out to do over that time, and part of that has been very much about increased attendances, but actually patients need admission, and that relating to a backlog of flow through the system. We have found this extremely challenging, but nevertheless there is some extremely good work that is going on in ED between ourselves and working with colleagues from NIAS to try and improve this, because we know that it's never good for patients to wait in ambulances and to be seen. So we are continuing with this as business as usual. The proposal is to take this off as an S&Q priority for next year. It's been on for two years now, but that's not to say that we are going to take away any focus. There will be more probably focus on this as an objective within the organisation and cross-organisationally. Reducing medication errors in relation to Parkinson's disease, and that was very much around the timeliness of those critical meds for these patients and inpatients. And we looked to get rid of over 60-minute delays completely. We decided to do this on 2 wards at NSEC, who predominantly receive the most patients with Parkinson's disease. And we have seen a reduction, but we haven't eliminated that 60-minute delay wait that we wanted to. 95% of doses administered within 30 minutes. Again, we've seen some improvement, but it wasn't to the standard that we wanted. We've got on the pilot wards, we've achieved that in 84% of patients, but we haven't achieved the 95%. And the rollout and education of training to staff on the essentials of inpatient hospital care for patients with PD. We've managed to get most of the staff, but again, we haven't quite achieved all of the staff on both wards. And again, that's because of sickness, just capacity to get the nurses. Even though it's a 3-minute training session, it's still extremely difficult to get those nurses and medics predominantly away from direct patient care. Improving cancer pathway standards. So this included all of our cancer pathways for this year, or for last year, sorry. And you'll see in 2 of the 3 indicators we have managed to achieve our targets, and they are national targets. But that 62-day treatment, first treatment, still eludes us in terms of our 85% target. We will be focusing on all of those for the cancer pathways continuously, and you'll see in the proposals for next year, we've specifically looked at a urology cancer pathway improvement project, because that is the pathway that causes us the most significant delays. Our deteriorating patient priority focused on community news. This was which is something that the district nursing teams predominantly perform on patients, so looking at deteriorating patient out in community, in patients' homes. And it helps to improve the communication between out in the community to transferring to hospital, for example. It also helps us to highlight patients that we think do need to be transferred to hospital, but also helps us think about patients who aren't best suited to come into hospital and they need to stay in their own home. So we've driven up compliance now. The last data that I knew of was around 85% compliance. So at the end of Q3, it was 60%. So that's continuously improved over the year. So that's been a really great effort by the community nursing teams. Improving delirium assessment and management. There were 4 elements to this. We've managed to roll out our delirium awareness training at trust induction. There is a slot now on in induction, so all staff receive that. The 2 that we haven't been able to manage to complete have been really around training of staff, and again it's that capacity to get the staff off the wards. What the delirium and dementia team have done is reviewed that training, and because it was a 2-hour training programme, they've re-looked at that. That's still an offering, but what they do now is they go to the wards and they deliver a much quicker, snappier training session. So we're collecting that data, but it's not what we set out to originally achieve in the first instance. And you'll see our patient and staff experience objectives are all on progress to be completed and were done by the end of Q4. We're just waiting on that clarification of final approval. So, for the year going forward, it says we've identified 7. We originally had 7, we've now got 9. So just by the sheer number, we are challenging ourselves even further. And you'll see that we've picked up on some of the themes from last year, but also looked at aligning that with our wider patient safety strategy as well. Because just to say that these SQ&I priorities are just a very, very small element of what we're trying to deliver from a patient safety and quality perspective. So we'd like to continue with our Parkinson's disease project because we haven't quite got there with the targets that we set, but we are going to, so one of the wards that we chose to work on has achieved their targets. So what we're going to do is extend that to another ward at NSEC, but also extend it into ED, which is where obviously our patients' pathways often start. These patients are often emergency admissions. So we'll continue to do the same targets into ED and another 2 wards. Improving cancer pathways. This is something that we discussed at our clinical policy group. So an idea that was raised there as a SQ&I priority. And this has come off the back of some complaints and some feedback that we've had as an organisation that potentially the patients who are coming through ED and discover that they have a likely or a suspected cancer, whether that be a new or a malignant tumour, they don't always get the best service in terms of it's not always clear at which point they need to go into which pathway. So what we're trying to do is improve that. It could be a cancer of an unknown primary, for example, and it's discovered when they come to ED. That's a very difficult thing for then ED to have to sort. So we're looking at working with the ED staff to be able to make sure that they know by using our specialist cancer nurses to go into ED to improve that patient journey. And so that the patients know exactly where their follow-up is going to be. I mentioned the urology cancer pathway performance. So that is our trickiest cancer pathway at the moment. It causes us the most delays. We are going to specifically look at the prostate cancer pathway because that is, again, the one that within urology, there are 7 cancer pathways. So the prostate one actually causes us the most problem. Part of that problem is that we are interlinked with Newcastle, so we have to refer into the tertiary centre for some of our patients, but equally some of that is within our control. So what we would like to try and improve in the first instance is that 28-day faster diagnosis. Because the faster we can do that, the faster we can then refer on if we need to. And we're going to try and achieve 75%. And there's lots of things that we're going to do across that pathway to try and improve that. Improving bed rail, bed height risk assessment and application. So bed rails have been a contentious issue for many, many years in hospitals and in patients' homes. They can be potentially very dangerous items of equipment in terms of entrapment of patients and patients who are potentially confused, climbing over them, increasing the risk of injury, etc. And what we've identified is that we are excellent really at completing the assessment, but we don't always follow through on that assessment outcome. So the assessment outcome might say to have the bed rails up, but actually when we go and look at the patient, the bed rails are down, and vice versa. So we need to make sure that we're not only good at completing the assessment, but we're following through on that assessment and repeating the assessment if it's needed. Pressure ulcers, so as well as falls, remain one of our biggest incidents, patient safety incidents that we see. And what we would like to do is concentrate on a patient pathway that we know that has a big problem with category 3 and category 4 pressure ulcers, which are the worst type of pressure ulcers you can get. But we not only want to target the worst, we want to start looking at actually when people develop a pressure ulcer. So it could start as something as simple as a moisture lesion in bed, for example, and that progresses right through to a category 4. So we want to reduce all of our pressure ulcers on the orthogeriatric patient journey by 25%, and we want to try and eliminate Cat 3 and Cat 4 pressure ulcers. We've included a maternity priority for this year, and this is something that we have identified. We're a bit of an outlier in the northeast for the numbers of, well, the incidence of postpartum hemorrhage of 1.5 litres or more. There's some discrepancies in data collection, so we know that some people are doing measured blood loss, others are doing estimated, and we know from the evidence that actually when you estimate blood loss, it's always less than what it actually is. We've always done measured blood loss, but what we've accepted is actually the position that we're at. It doesn't matter where anybody else is regionally, we want to improve that. Infection prevention control, thinking about our patients who have developed UTIs and potentially gram-negative bloodstream infections, often associated with catheter use. So the infection control team were very, very keen that this was on as an improvement idea because they had identified an increase in the incidence. So again, working with the IPC team to think about ways to improve that. And generally that is through good catheter care. So it's going back to basics, back onto the wards, working with the ward staff to really understand what good catheter care looks like. Our deteriorating patient, we want to keep this on as a priority. It's something that we focus on. We've got a deteriorating patient board that oversees all of our improvement metrics from a deteriorating patient point of view. But the 3 that we've picked out particularly are around recognising patients who are deteriorating. So making sure that observations are done on time and that all of our staff are logged into their handheld devices, so that the escalation pathway can work correctly. Realistic around actually making sure that our treatment escalation plans are appropriate. So we are very, very good at completing treatment escalation plans when patients are admitted. What we need to now measure is actually the appropriateness of those treatment escalation plans. And respond is the final one. So we know that we're an outlier on our National Emergency Laparotomy Audit, particularly from the decision to operate to arrival in theatres. It should be about 6, well, the standard is 6 hours, and we currently sit at 10 as an average. So we're working towards improving that target specifically. And then our staff and patient experience metrics, we always include these, but we just change the projects within them. So we've identified a number of projects within this one, which is around employing technology to improve our staff and patient experience programs. And then finally, skip too far, around establishing approaches to involvement and engagement for both patients and staff, which is promoting equality and inclusion. That's it.
Awful lot in there. Before I get to questions, thank you for that. That was very comprehensive. Councillor Hill, is this about Berwick?
Thank you. Just to draw out a couple of points and a couple of quick questions. First of all, I think every time we get these accounts, the same picture emerges, which is not hitting targets, below standard. But the good news is, if you can call it good news, there's others. It's performing even worse. I mean, that's the picture we're constantly getting, and it is obviously disappointing to see, you know, that some stats are quite striking. I mean, the target is 95% of handovers from ambulance within 30 minutes, and it's 64.7. Target of 65% of handovers within 50 minutes, and it's 26.7. That's obviously disappointing. And the cancer stats that are just under a quarter of patients aren't getting treatment within 62 days, which is obviously results are potentially very serious. Don't need to spell that out why that's not happening, so that's disappointing. In terms of just a couple of questions after pointing that out, in terms of the ambulance handover, can you just explain to me, is it when the ambulances arrive, you know, in order that the scene, or is there some sort of triage system? Because you can understand that during the journey, whatever, there's obvious ones that need to be seen, even if they're 8th in the queue compared to. So if you could explain to me exactly how that works, and if there is a sort of triage about who's seen, not just first come, in terms of the ambulances. And then your overriding point at the beginning, the third point down, could you explain what this means? Because it sounds a little bit sort of wishy-washy, for want of a better expression myself. But impact of industrial action, minimal cancellation of activity, but increasing impact on resilience of teams. I mean, what does that mean exactly? And could you just spell it out? Because quite obviously, if as we've seen with these other stats, the service, if everyone's, not one person's off sick, everything, you can't meet the targets. If people are going on strike, you're obviously not going to be hitting the targets. And I know there's a sensitivity. You don't want to be completely open with the public because you don't want the criticism, but the strikes are obviously affecting services even more. So if you could spell out what exactly the impact has been. Thank you.
Right, there's a lot of questions there. And considering we've got... There's quite a few. But we have the ambulance service here as well, and if Mark or anybody wants to comment, I will allow you to chip in, is probably the best word, if required.
I think the two questions I've heard, the first was around prioritisation. So patients aren't, from an ambulance point of view, there are pre-alerts. Somebody who is at high clinical priority will be seen straight away, be it if they walk in or if they come in an ambulance. The ambulance handover delays, it's fair to say there are a number of people who are conveyed to us in an ambulance that in another situation would have come in a car, and actually they're then prioritised and probably at a wait longer than somebody higher prioritised. So it's not a case of first come, first served. They're all seen in terms of clinical need rather than waiting. And Mark can come in on that just to reassure you. So the clinical need, and that's exactly the same as somebody who walks in. Somebody who walks in is triaged and assessed. They may wait 4 hours, they may wait 2 minutes, depending on their clinical situation. In terms of the second point around industrial action, we have made a real effort not to cancel operations, and that's not spin, that's absolutely the case. But I think it's fair to say we have a number of people who aren't striking, therefore they are taking up more work as a consequence. So it's fair to say that if you then look at the pressures that we've had over winter, plus the pressures of strikes, that just has an effect, which is why we're saying there's an impact on the resilience of teams. So you're having a busier clinical workload as well as covering for strikes, and it's that is meant by the wording.
But is there any specific stats around the effect of industrial? It's obvious, you know, we know it's an evidential point, but this is going to happen, but it'd be good to have some stats around the effect of industrial action. We do
staff surveys, and quality accounts are very much there focused on our problems rather than our successes. So certainly our staff survey would say that we've got the of acute trust, we had the highest staff satisfaction across the NHS, but it doesn't isolate individuals who are striking or not striking. There's no way that you can legally look at differentiating between those individuals. It's a supposition that's having an effect.
When there's industrial action, the
Right,
stats
no,
at the time, but this is important, Chair, if, you know, surely you can draw some stats to see more effectively what the effect is of industrial action. So the times when there is industrial action, when the time that there isn't.
Well, you don't do, the surveys are done monthly, so it would depend on those monthly stats. We've not seen an enormous shift in staff satisfaction throughout the period.
But it's not about staff satisfaction, it's about the impact of services when they're striking.
So again, those would be brought out on a monthly basis with regards to waiting times for elective procedures and A&E performance. What we have seen is that A&E performance hasn't been compromised at all during the strikes, mainly because actually there are more consultants actually present instead of junior staff. The more concern is that it's the planned procedures that are cancelled to free up the consultants to then man the front of A&E during the strikes.
Right. Councillor Hunter.
Thank you, Chair. Yes, there's a bit on the ambulance handovers and AED, because on the national news today about the amount of patients. So it's a bigger national picture than Northumberland, and I think maybe nationally something needs to be done about it to try and move it, because if we can get them through ED, it allows the staff to move on and allows the ambulances back on the road. My question was more on the cancer. I've had 2 or 3 residents in contact with me lately receiving updates on that tests from cancer. They know they've got cancer, but they're actually just receiving updates of the maybe progress of the cancer, that the situation's getting worse, either in an evening or a weekend, so they can't actually contact their doctor to see what the texts actually mean. Yes, as a clinician, you'll understand what the texts are, but as Joe Public, and the automatic thing is to Google it, because we're human, and it's a case of just wondering why all of a sudden these texts are starting to come out, rather than go through the doctor, so that the doctor can guide them as to what it actually means and what the situations can be.
Are those coming from the GP or from the specialist? Because most of us...
I'm led to believe they're coming from the specialists, not from the not from the GPs, and it's just, it seems a bit strange that, you know, because the GP at least has a clinical understanding and can guide people as to is it worse, because we do panic, if you know what I mean.
No, I think it's a fair comment. I think some of this is, if it's coming through the portal, so it'll come through the doctor portal. And I think you raise a good point. If people are sending things at evening and weekends, we probably should just take that and feed that back, because I think you're right that it raises issues where people can't then contact the service. So I think that's a very fair comment. We don't need to go into specifics, but I think that's a very well made point. I'll take that back directly, because I think you're right that where there is an information, it's not necessarily neutral, as you're saying.
Councillor Nesbitt.
Yeah, mine's just on comment more than anything. Right. Mine's just a comment more than anything, because as an inpatient I was in, and it was through the strike, I never noticed any difference whatsoever. The care and profession from the NHS was absolutely amazing. So I can't fault that, so I don't know why. I know you're saying you can't get the stats for that, but it's just more the comment that I never noticed any difference through the strike. It was really well, everything just went through really good. So I can't comment on saying about the strikes having an effect, because to me it didn't.
I think to agree that is partly borne out by both staff and patient surveys, which we do monthly, and they're not dipping particularly. So, but we don't just survey on a strike day. We survey on an ongoing monthly basis, and we've not seen significant shifts. So what you're saying backs that up.
Mm-hmm. Right, before I come in, anybody? Anybody again? No? Right, we've got the Ambulance Trust and yourselves here. Why is it always Christmas? Is it because Christmas is now such a big thing? and staff have to have time off as well as everybody, and certain people get drunk, and go to A&E on a Friday night is like a soap opera, waiting to happen. It never. I mean, we've just had Easter, and Easter doesn't seem to have the same sort of impact as Christmas. And Christmas does come round every year. How are we ever going to lance this?
I don't think
weights and times and.
I suspect it's twofold. That there is the bank holidays, but you're right that Easter's the same. It is more the fact that this comes in the middle of winter, and so if you look. Not so much this year, but last year you had Group A strep, we had flu and COVID all arrive at a peak within the 10 days of the bank holidays. So it had a cumulative effect there. We didn't have the same peak of illnesses this year as we did last year, but Christmas is normally, we actually look at winter as starting sort of November time and going through till the end of February time. And we can see that there is an increase in the acuity, there's an increase in the number of complex frail elderly that are admitted, mainly because you don't need very much in terms of respiratory or other infection to take you from I can cope at home to actually I can't cope. And it's just particularly when we have an elderly population on average, which we do in Northumberland, little bits then tip people over from coping to not coping and actually result in significant deteriorations in their health. So I think if we had an Australian Christmas, with it being in the middle of summer, we wouldn't be talking about Christmas in the same way.
I mean, I feel sorry for, you just touched on morale and how staff feel. I mean, we're into an election year, and I feel sorry for the staff that they must have to just listen to stuff and go over their heads. Because my experience with the NHS has been excellent. They're really trying to fix you. Yet politicians, this broken NHS, the words that are used are not helpful in any way, shape or form. But that's for them, and we're all politicians to a degree, but not at the scale that, the football, the public football is about to be put on the pitch. So I feel sorry. Anybody else? Councillor Bowman, for a positive question.
It is a positive question. Thank you for looking into people who suffer with a loss of hearing. I myself are one of those people, and I know from examples of the past, I'm talking about 20 or 30 years ago, attending hospitals and not hearing somebody calling out my name, and the simple things like that. And therefore you miss your appointments and so on, and it gets really complicated. But thank you very much for identifying that as an issue and doing something about it, because it's not just related to one's hearing. It can be related to one's age as well. As we all get older, our hearing deteriorates, and some people unfortunately probably haven't had a hearing assessment, and they themselves are suffering in a waiting room, not being able to hear their name being called out. I just wanted to make that point known, that not everybody who's registered, as it were, deaf or with a hearing aid has hearing problems, but thank you very much for looking into that. It's very encouraging.
Thank you. Anybody else before we move on? Right, I think we're done.
Thank you.
Thank you for this update. Chris, do we need to do anything, or is it?
Sorry. We'll submit a formal response to the quality accounts, which I'll write based on the discussions that we've had.
Thank you very much.
Thank you.
Thank you.
Right. Now then, glasses. Never mind hearing. 5. North East Ambulance Service review of performance in Northumberland. And Mark and I go back a very long way when I was on the trust or the board or whatever it was of the NEAS. So Mark,
Thank you very much, Chair, and it's good to be back here again. I will give the presentation, and with my colleague Claire Jobling, between us, we'll try and answer your questions afterwards. So my presentation is in two parts. One is giving an overview of performance as requested, looking at 111 and 999. And in your pack, there should also be a breakdown of performance by area, which was requested earlier. And then the second part of the presentation will be just like our last agenda item, an overview of our quality account. And we're in that time of year. So just moving on to performance, first of all, I'll cover off 111 first and then go on to 999. You can see here that the data on the number of calls triaged on 111 in Northumberland is there for the last 12 months that we have most recently available to us. And the average call to answer those calls dates back over the last 3 years. You can see there that the average time to answer 3 years ago was incredibly long. That started to come down, but we spiked again in that winter period of 2022 into 23. And as our last speaker spoke about, it really is about that season of the year, that time of the year being winter rather than necessarily the bank holiday period solely. But within the last 12 months, you can see that our average call answering has really significantly reduced and stayed there. And that's been as a result of a lot of additional investment that we had from our commissioners and quite a significant recruitment drive that we've done for call handlers into our organisation. We're unique as an ambulance service operating 111 in that we operate what's known as a dual handling call. We have dual call handlers. What that means is that they can answer both 111 and 999 calls. And while the way that that call is initially answered will be different depending on the number that you dial, the person taking that call and the system that they're using is the same. So that if a 111 caller really needs an ambulance, they will seamlessly transition into that as though they'll run 999. Similarly, a 999 caller who needs some other kind of help, not an ambulance, will similarly transition as though they'll run 111. In terms of the outcome for those calls, you can see there that the blue line represents the outcome of 111 calls across the whole of the North East Ambulance Service area, and the red line represents those 111 calls across Northumberland County. And on the whole, there's probably about a 2 percentage point difference in the outcomes of those calls where they needed to attend an emergency treatment centre. Slightly lower in Northumberland, although the pattern of the rise and fall of those calls throughout the year is more or less the same. Whereas those calls where the advice is to contact into primary care is pretty much indistinguishable. There may be only a percentage point difference in that. But again, the pattern there is following the same line as right across the rest of the service. If we move on to 999, you can see there both two charts. The blue one represents the incident volumes of 999 calls that we attended, an ambulance attended, throughout by month throughout the last 12 months, and similarly the incidents attended across Northumberland. And again, the pattern there is similar. And just to pick up that point about winter and Christmas, the two highest peaks of demand there are December and January, both in the county and also right across the service as well, where we're seeing, because of the colder weather, we're seeing a larger outbreak of particular illnesses and conditions that you wouldn't otherwise see in other parts of the year. Now, the ambulance services, I'm sure you all know, have response time targets to achieve for 999 calls where it's determined that an ambulance should arrive. These are categorised into 4 categories. The first being a category 1. These are the most serious, potentially life-threatening calls. They relate predominantly to cardiac arrest or respiratory arrest, and it's measured by 2 particular standards. The first standard is that 90% of all category 1 calls should receive an ambulance within 15 minutes. And the second standard is that the average of all calls should be 7 minutes. Now, the reason we measure the average there, as well as the 90% target within 15 minutes, is a legacy of the old system. I don't know if you can recall that, where the ambulance service had to respond within 8 minutes in 75% of cases. And no one ever thought about or asked, well, people did ask, but no one ever recorded what happened to that other 25% that didn't get that ambulance within 8 minutes. So this is what the average figure is measuring. So it's measuring that tail of delays, as it were, that didn't meet the ambulance response. So the longer the average is, then the longer you have experiences or examples of patients who have waited. And obviously those patients that wait a significantly longer period of time will push up that average response. So the average response for the ambulance service is that we should meet all of the category 1 calls within 7 minutes. You can see across Northumberland that we are above that, and it's in the 8-minute mark, or thereabouts, between 8 and 9 minutes for each month over the last year. Whereas the 90% of those calls could be achieved within 15 minutes, have been achieved or is close to that achievement across Northumberland. That probably reflects, well, it does reflect the nature of the county. It's a large county with some semi-urban, some urban and some rural and semi-rural areas. And that the distances to travel for some of the category 1 calls from where our ambulance may be dispatching from is going to be further than the distances to travel in other parts of the region. But you can see there that the performance of the ambulance service, of the North East Ambulance Service, is that we are one of a handful of trusts that are achieving that 15-minute response time within 90% of cases. And we're the only ambulance service in the country to have achieved its average response time of under 7 minutes, and that's been consistent right the way throughout the year. And I'm conscious of a question earlier about benchmarking, and the reason we put this up here is to give context to how ambulance services across all of England are performing, not just here in the North East. So the second target is known as Category 2. So these calls tend to be not immediately potentially life-threatening, but the conditions within them can become life-threatening. So these are heart attacks, these can be strokes. What we found since the introduction of Category 2 about 5 or 6 years ago, something like 7 out of 10 of all 999 calls that we receive now fall into this category. So that puts an enormous burden upon all ambulance services to achieve the standards. And the standards here are that 90% of all Category 2 calls must have an ambulance response within 40 minutes, and that the average response for all Category 2 calls must be 18 minutes. And you can see there that the red bars indicate the performance in Northumberland, and the blue line indicates the performance across all of the North East Ambulance Service. So while that's not been achieved either in the county or across anywhere else in the North East, the county performance for Category 2 is faster than the average performance across the whole of the North East Ambulance Service area. And again, this comes back to my earlier point about the makeup of the county and the distances the ambulances have to travel, and that once an ambulance is responding to a Category 2 call in Northumberland, it is less likely to then be diverted to a more serious Category 1 call, because it's not necessarily the closest ambulance there, and therefore will it get to its Category 2 call quicker than, let's say, an ambulance in a more urban environment, which is on its way to a Category 2, but then it gets diverted to a Category 1 call, because it still happens to be the closest vehicle before it's arrived at its original patient. So that's why we tend to see that performance across Northumberland in this category slightly better than across the rest of the area. But we're a long way off trying to achieve that target. And I just want to spend a little bit of time just explaining about what we've done, Chair, in order to improve our performance in this particular area. And you can see there how we benchmark Category 2 performance across the rest of England, and that no ambulance service in the country is meeting its Category 2 performance, and no ambulance service in the country has met it at all within the last year. So moving on to why this has occurred and what we're doing about it. NHS England recognised and acknowledged this as an issue that needed to be addressed last year, and they introduced a new guidance for the average response time to Category 2 to be achieved within 30 minutes, and for that to be achieved not just by the ambulance service but by other partners as well, such as hospitals ensuring quicker turnarounds while the ambulance once the ambulance has arrived there. And obviously you've heard from that from the previous presentation. Now I should just say the 30-minute target is just the guidance from NHS England, but we will always still show our performance as it's measured against the 18-minute target. And that's because when the 18-minute target was introduced, it was introduced because there was clinical evidence behind there that sat around why the ambulance average response needed to be there at 18 minutes, rather than another arbitrary number such as 30 minutes that has been achieved. So we're not there at the 30-minute response target either, but we are working towards that. But we mustn't forget that the actual target is 18, and that's where we really need to move to. In terms of what we're doing about it, so you can see from this chart here that the average daily incidence that the ambulance service attended has increased over the last year, and that yellow line in January indicated the largest number of incidents that the ambulance service has ever had to respond to in a single month. An unprecedented number for us in terms of in terms of the demand upon our service. You can see there that that orange line represents where we should have been in order to achieve that 30-minute standard, what we do expect that incident volume to be. And that gap there is beyond the forecast number of demand that we had on the ambulance service. So we've done a number of things in order to address that. One is around actually validating the calls that are classified as Category 2 in the first place. Now, I mentioned to you that 7 out of 10 of all of the 999 calls that we receive are initially assessed as being a Category 2 call. What we were doing before November, December of last year was then having clinicians working through that stack of Category 2 calls and revalidating those calls. Just what we mean by that, to check, are you actually a Category 2? I'm a clinician now rather than a call handler. If my conversation with you, is there a better pathway, is there a better way that we can treat you other than sending an ambulance? And we were diverting about 15% of those Category 2 calls into other dispositions other than sending an ambulance. At the end of November, we introduced a new system where we know that there are particular types of flags on calls that have a particular outcome. So we introduced these flags into our system that allowed our clinicians to much better and much more quickly identify those particular calls that could be dealt with alternatively, so that they could pick them out of the system quicker, make the call to that patient faster, and make that assessment sooner than they would have done. And as a result of that, we've actually increased the number of calls that are diverted away from being a category 2. From the 15% I was saying earlier, that's now up to 22% of calls that are going to another disposition other than having an ambulance sent to them under a category 2 response. So it's making some headway in that particular unmet demand for ensuring that we're not sending an ambulance to those patients that could be dealt with elsewhere, and therefore those patients who do need an ambulance back are getting it as quickly as possible. The other thing that we have done to address is increased capacity, because when demand goes up, then obviously having more staff on the road, more vehicles with wheels turning will go some way to doing that. And again, this chart shows you on the blue line how we've increased that capacity, and the orange line shows you where that increased capacity ought to have been in order for us to have met that 30-minute average. So you can see there that actually we put out more vehicles and more staff hours onto the road than we forecast we would need to do in order to achieve that NHS England guidance of 30 minutes. But because that demand was so much higher than was forecast or anticipated, we weren't able to achieve that. And again, you can see there in January, I talked about that being the highest month that we've ever recorded in our service history of demand. It's also the highest month that we've ever had, the largest number of resources on the road to meet that. I talked earlier about the significant investment that our commissioner has given us in the service to improve call handling on 111, and that investment obviously reflected back in ambulance response times as well. So we've been able to get 8 additional ambulance vehicles with their 24/7 staffing rotas that they needed onto the road I'm going to say in this year, but I'm thinking about financial year, from the last financial year. And as of yesterday, in this financial year, we're hoping to get a further 7 extra ambulances and their crews onto the road as well. We've increased in enormous our paramedic workforce. We've worked very closely with the 2 universities in our area that train paramedics through their 3-year degree course, encourage them to oversubscribe their courses because we have places for them here for them to come and work in afterwards. And we've also increased the number of third-party providers, because it takes 3 years to train a paramedic. It takes at least 9 months to build an ambulance vehicle. But when you're given the money now, we want to put that money to the best use possible for patient responses. So we have seen an increase in third-party providers on our road. That's not what we want. We would like to have all of our own staff employed by us responding, and that's our ambition, hopefully, that one day we'll get there rather than using those third-party providers. But that helps us in that short-term gap while we are going through our recruitment programme and going through our capital programme for additional ambulances. The impact of all of that in terms of us trying to achieve initially our category 2 target, average target, initially to meet the NHS England guidance of 30 minutes. You can see there what we did achieve on the blue line and what we expected to achieve on the orange line, which means to say that at some points in this year, we have actually achieved that 30-minute target. We haven't done it at every point of the year, and as we've just gone through that winter period, the last couple of months, we've just been above that 30-minute target. But we've made significant progress towards achieving that as a stepping stone towards, as I said, the important element there, which is not forgetting the target there is 18 minutes for the average. Finally, the other 2 categories of calls for ambulance services, category 3 calls These are less serious urgent types of calls. There is only one measurement standard for this call, and that category 3 call should have an ambulance within 2 hours in 90% of all cases. And then a category 4 call, which is the least serious of all, should have an ambulance response within 3 hours in 90% of all cases. And you can see there again that across the county, the response times in both categories are significantly below those of the North East Ambulance Service area. And in category 4, the response times there look to have almost been achieved in almost every month in the last year, where it hasn't been the same picture for that across the service. And you can see there how we benchmark against other ambulance trusts in England. Again, just to give you that context of the national picture of ambulance service response times in other parts of the country. And then finally, as we talked about at in the last presentation, is hospital handover performance, and I'll come on to this again in our presentation on the quality account. This is now an issue that has a much greater awareness than it perhaps did 2 or 3 years ago. So much so now that it's a focus of attention, both for the ICB, it's a focus of attention for NHS England, it's a focus of attention for the Department of Health, and actually I believe now that the Secretary of State receives a weekly report on ambulance handovers on her desk, which is something that hasn't always happened. The key point to talk about amongst ambulance handovers, of course, is the question that was raised before, is that it delays the ambulance crew from being able to then turn around and respond to the next available calls. I won't say too much more because this is actually going to be part of my next slide on the quality account chair. Just before I come on to that, I won't dwell on this slide too much because members will be aware of what the process now is for the quality account. Just to say that we'll be starting our formal consultation on our quality account at the end of this month, looking for responses by the end of May. We'll share that through your officer to distribute amongst members for a response, and we will publish all of those responses along with our quality report at the end of June. In terms of some of the highlights in our quality report, obviously patient safety incidents is a key area of focus. You can see there that the proportion of patient safety incidents per 1,000 calls is listed there at 2.2%, slightly higher than that of last year, although the data there only represents figures up to the end of December. It hasn't taken into account the last quarter, and we do expect that figure to drop. Part of the reason why we have that slight elevation in the proportion of incidents is because of that winter surge pressure through November, December, January. When you get that increase in demand, you tend to see an increase or there is a risk of potential increase in risk of harm or patient safety incidents occurring. You'll see that the number of patient safety incidents has more than doubled, and the reason for this is that we took a decision to change the criteria on reporting patient safety incidents and serious incidents, and to record all of those ambulance delays that took longer than an hour beyond their standard target response time to be recorded as a patient safety incident, which is why that's more than doubled. 88 serious incidents are recorded in there out of that number of 140 up to the end of December as a result of those ambulance delays. That does mean that our figures aren't comparable with other trusts because there's no criteria that is set on how these are recorded. But we felt that given the nature of the job that we do and our priority had to be to patient safety, that it was the right thing to do to change our eligibility so that we are reporting a higher number and are transparent about doing that. You can see there from our patient feedback, just like the Northumbria Healthcare Trust talked about, we survey our patients. In the last year, we surveyed more than 10,500 patients who have used our 111 service, dialed 999, receiving an ambulance and be treated at home or have been taken into hospital. And you can see there that those percentage figures up to the end of December of the last financial year compared with the full year before all of that, there's no significant variation, although the figures are slightly variable in number there. There's no significant variation that comes through in all of that. The number of complaints you can see there in the appreciations that we've received, again, are up for the 23-24 year, are up to the end of December. And I should just say that the number of complaints are falling. Our forecast complaints for the end of the year are forecast to be slightly lower than the 22-23 year. And when we look back over the last 4 years, there has been a trend of the number of complaints that has come down. In 2019-20, we had the highest number, 436 complaints. In that same year, we also had the highest number of appreciations, which was 914. And you can see here that for the year that's been recorded here, we've already broken that figure for the highest number of appreciations. The themes that come through on both complaints and on our patient surveys are the same. They tend to be around staff attitude, the timeliness of the response, and the quality of care. And actually, what we find in appreciations as well is that staff attitude and the quality of care are also very highly rated in the appreciations as well as in the complaints. Moving on to our quality priorities, I would just talk about our progress against the 4 priorities that we set ourselves for this year and where we see ourselves going for next year. The first one, which I mentioned about, was hospital handover delays. And as I've mentioned earlier, there's now a much greater system ownership of hospital handover delays. We have carried out a thematic review of those patients where we have considered that a handover delay had caused moderate harm or below moderate harm for the patients. As we already look at those cases above moderate harm, we wanted to look at all of those other cases to see whether there was anything new out of that, if there was something that we were missing that we needed to take account of. What's quite pleasing, though, is that while we undertook that work ourselves for our quality account for this year, nationally, NHS England are looking to introduce what they know as an ambulance data set across the whole of the country, which will look to make that thematic process standardised across all ambulance trusts moving forward. And there's now much greater collaboration and much wider system ownership of this ambulance handover delays. So it's important to recognise the handover delay is symptomatic of other system issues rather than being the fault or the blame of one particular service or organisation. And as a result of that focus on there, we're quite confident that that focus is here to stay. We don't need this to be a quality priority for us for next year because that focus will be made elsewhere. So we'll be looking instead at a new priority that will be looking within the area of learning from incidents or learning from patient deaths rather than specifically handover delays, seeing how those other systems have been put into place for us. Our second priority was around the introduction of our patient safety incident response framework, or we love an acronym in the NHS, PSIRF, as it's known. Prior to this, we had made some considerable work in strengthening our governance processes around patient safety incidents, making them much more robust. But with a view that we were always going to move towards this new framework of patient safety response incidences, or PSIRF, as they are. The PSIRF has been introduced across all NHS organisations. The requirement is that it should be introduced by the 1st of April. We introduced PSIRF into our organisation on the 1st of January. And for the last quarter of the last financial year, we've been running PSIRF alongside our patient safety incidents. So we haven't opened any new incidents under our old process, but we've done that through the PSIRF system instead. Our aim was to close all of the patient safety incidents under the old process by the end of March. And of the 99 that we had open in January, we closed all but 2 of them. And the 2 that haven't closed are quite complex cases which have, for their own merits, deserve to be remained open and to have that particular focus. I should just say, though, that while the incidents are closed, the action points that arise from those incidents are still very much open and are being monitored until we are satisfied that the actions that arose and the recommendations from each of those particular incidents are closed out. But we're now we now have PSIRF fully embedded into our organisation, and as a result, again, we don't feel that this is going to be a requirement for a quality for a quality priority for next year. But instead, I think coming out of that will be having a new PSIRF system in place. Our learning from that and our learning from those patient incidents, and our quality priority will sit within that sphere rather than necessarily the implementation or introduction of the system. The third quality priority we had was the implementation of what's known as clinical supervision. I should just say that what we mean by clinical supervision is a facilitated discussion with clinicians, mainly our paramedics, but other clinicians as well, out on the road, that's built on trust, respect and psychological safety. And we've been on a journey throughout this area for the last 5 or 6 years. We were one of the first ambulance services to introduce frontline management support for our clinicians on the road. That frontline support then did ride-outs and observations with their crews. What this next step in clinical supervision allows is for protected time for our clinicians off the road to have that safe space with their clinical manager to do reflective learning, reflective practice, and to raise questions and have that discussion around their continuous professional development. And for the first time, this standardises the professional development for our clinical workforce in the ambulance service. That, again, we have now been able to successfully implement into the service. But as it's relatively new, it's still something that we are working through. Our final priority, Chair, was around increasing service users and staff involvement in our patient safety and patient satisfaction activities. And we've done this through a number of different ways. We've appointed 4 patient safety specialists who are not from within our organisation into our trust to support us in this piece of work. We've identified a lead on our board for patient safety as a patient safety partner, and have widely involved other stakeholders and specialists in this area to support us in all of this. We still need some work to do within all of this, particularly establishing a patient feedback group, we have an enormous amount of feedback already from patients. I mentioned our survey, 10,500 responses. You saw there the complaints and appreciations that we received. But while that is all quantitative data, as it were, we want some more of the qualitative data that we can get from setting up a group where patients can, can come in and tell us and make sense of some of the interpret some of that data for us that we're seeing in some of the feedback. I'll pause there, Chair. I'm conscious I've been talking for a while. I'm sure there are lots of questions.
Got the local data, and I would like to go through that after we've done the questions, as in so we can understand it. Okay. But Councillor Hill.
Thank you. I'll start on a positive note. I was a few months ago in an ambulance for the first time in my life with a family member, and the service was outstanding, from the speed of coming, the service on the ambulance, the communication, which was interesting with the hospital specialist departments, because the relatively, I think it ended up just a low sodium count, which created delirium, but it looked like it could have been a stroke, and the communication to establish was impressive. And then ambulance drop-off point seen straight away, so that and I hope I did. I remember thinking I have to email in with that positive feedback. I think I did. I'm sure I did. And it's really good because I've raised this before about having the localized data, and that's really helpful to see the picture, because I actually, through an FOI, got the information for the TD15, the Berwick postcode area, and I mean, obviously it's far from perfect and beyond more than the national standards, but it was better than I thought. I thought that it may be more worrying, which it wasn't. Wasn't as bad as I thought when I got that data. Just coming to question, it is though. I mean, if you look in North Northumberland, the response time for Category 1. Is average 10 minutes 13 seconds, which is just above the national standard, isn't it? But that compares to 6 minutes 31 seconds for the Seaton Valley area. So that's a 3 minutes 42 seconds difference. And that, and I've just looked up to some clear on this, I knew it wasn't very long, but for example, if somebody has a cardiac arrest, the brain can only survive 3 to 4 minutes. So I think that shows how stark that difference is. So it's just getting on to presenting the data, because what is obviously happening, and we get this feedback from residents, there's many experiences of ambulances coming very quickly, even in the rural areas. But obviously there's still times which obviously can be fatal and very serious, being very late, very delayed. So it's just about accessing and presenting that data. So, you were taking an aggregate, an average, but the amount of times when it's long. And you did say that if it's over an hour, it's recorded. Is it automatically recorded? So this comes from, is it automatically recorded if somebody has to wait for an hour for Category 1? Or is it only if they think it results in the delays cause death or whatever?
It's the latter. It's a serious incident. So where over an hour there's been a detriment to the patient safety, where we think that delay may have contributed towards that.
Right. So that's any time you report it? Yeah. Okay. And there's no other way of getting the access, so it's this aggregate figure, what sort of percentage have to wait an hour longer in North Northumberland? We don't get that data.
I think you could probably get all of the incidents plotted, so I think you could see that. But what I would hope to see is an hour for a C1 emergency would be an ever event, because of, the resources that are freed up to, obviously C1s were highest priority. So if you are travelling to another incident, you will be diverted from that incident. I think that's what Mark was trying to explain before. In more, the city centre areas, you'll have more ambulances probably being available, but that are tasked to C2s. So then they're diverted quite quickly, so our C2 performance goes up. Whereas in Northumberland, if we commit somebody to a C2 response, they'll have been travelling, we'll already be moving other vehicles up to support that. So it's a bit like we'll move our resources around. So if somebody goes out at Berwick, then Belford will go up to Berwick and Alnwick will go up. So we're forever moving them resource about. But I would say an hour would be an ever event for a C1.
Yeah.
Anecdotally, you do hear it's more category 2, but the instances of which isn't life-threatening, but somebody's in agony with a snapped leg, basically. You know, that's not pleasant to wait for 2-3 hours. We do hear of these examples that are happening, and obviously people will talk about it if there's happenings, and it just seems to understand the system of moving about, and it just seems that it generally works. But if you have, I think, just in a high proportion one day, you know, there'll be an average of roughly amount of maybe time of year or whatever incidents per day. But if you have an unusually high or a bigger event or something, then a bit unlucky movement, there are occasions when this does happen.
So
It would
I
be
thought the
good to know
question was
exactly
around
how much, yeah.
I think the question was around the C1 originally, so that's what I based my answer on. From the C2 point of view, obviously our crews do report them. If they get on scene with a patient that's poorly and they believe that there's been a delayed response, then they can put in a patient safety incident. Also through the complaints that we can get received from staff, then that'll be measured that way. So there is other reporting mechanisms that can come through either ambulance crews or for the patients that are affected where they've been experiencing longer delays. But I am sure that we can get that data to show.
Right, I've got Councillor Hunter. You've had a fair old whack at that. And the Berwick figures are better than we all were led to believe. So I'll go to Councillor Hunter.
Thank you, Chair. First of all, I'd like to congratulate the staff, because the ambulance staff, they're always appreciated. And, you know, it's a case of where they are. Does the clock stop when the first responder arrives? Because sometimes the first responder arrives first, because often that can put family at comfort if they don't know what's wrong with a relative, but can I say a medical one's arrived on the scene, so that thing be. So does the clock stop then, or does that it only stops when the actual ambulance arrives?
The clock stops at the arrival of the appropriate person to treat the patient's need. So if you have the example that Councillor Hill gave, a patient with a broken leg attended by a first responder, that wouldn't stop the clock, because that's not what the patient needs. The patient needs transport, and therefore the only thing that will stop the clock is that transport and pain relief that would come along with that.
I think it's that understanding, is that. And another couple of questions is the vehicles. Hopefully, nice to hear that you're getting more vehicles coming on site to give you more support, and hopefully they'll be spread across the county if they can, or where the needs are, which frees up others. And the 111 callers, are the numbers going up more for the fact that people can't get doctor's appointments? Because often if you phone up, and you've not been the lucky ones at 8:30 in the morning, you get told, well, phone 111, because they can maybe free up, get you a doctor's appointment. So that's going to put more pressure on your service, as I say. So I don't know if that's increasing your numbers.
I think for me, obviously, if you can't get an appointment with your GP, we also hold the ledgers through 111. So it's an appropriate signposting to get people seen within the system. What I would say is that they don't always generate, just because it comes through 111, Mark demonstrated before, there's a small proportion of them actually need an ambulance response. And we do obviously look after them in different ways, but we do hold some of them appointment ledgers and can get people seen within the hub. So it would be appropriate that they are directed if they couldn't get an appointment.
Thank you.
Right, I mean, when I was on the trust or whatever, there was this obsession with stopping the clock, and I know that's changed somewhat of late, but it was like, get someone there. It wasn't a case of having the right person there or whatever. It was just try and stop the clock. And if you live in rural areas, it's going to take longer. Unless you've got 3 or 4 helicopters at your disposal, you know, it's a longer time. That's just the way of living in the countryside. My question is about the PTS, the Patient Transport Service. Because, I mean, when I was on there, there was a spike in the use of that, where ambulances or the transport services were used, and there was a couple of BMWs, not that I know about BMW drivers, but just there was a couple of swanky cars on a driveway, and they were using the PTS service because they didn't want to pay the extortionate hospital parking. Is that still a... I mean, it's not like the airport, that's beyond extortion, but is that still the case where there's abuse of what I'd call the PTS system? And
there's a criteria now, so when patients get obviously PTS booking, then they're taken through a criteria, you know, whether it's a dementia patient that needs somebody to come with them, whether, you know, they need support when they get to their end. So there is a tighter criteria to try and negate some of that misuse.
Right, okay. Anybody else? Councillor Bowman.
It's just on a practical matter of transportation around our road networks. Am I thinking right when I look at our road networks are getting busier, especially around rush hour in the mornings and in the evenings? Is that having an impact on your services as well? Because I realised that during COVID and thereafter, people were working from home, and that's not so much the case now. Is that having an impact on your service as well?
No, I don't think it is. We have looked at, I have particularly asked that particular question, looking at study of response time and the different factors that come into it. And there's nothing that suggests that there is a material impact as a result of volume of traffic on the road. Now, I should just say that's what the stats are telling us. But that doesn't mean to say that on an individual case, an ambulance might have its progress slowed down more than it expected to. But the overall stats are telling us that if that's happening, it's not having an impact on our response time figures, if that makes sense to you.
Okay, anybody else? You okay?
Yeah. Just talking.
Claire, if you can sit down among the councillors here and get a microphone if you ever wanted to speak, but I just noticed that. Mark, can you take us through the localised graph?
Yeah, of course.
Is that possible? Just so we just pick any one. Obviously not North Northumberland because they're too good.
Just while we're getting it up on the computer so we can take you through it. I just wanted to come back on...
this is new to us.
Yeah, no, I appreciate that. I just wanted to come back on a question that Councillor Hill asked earlier, just to make a couple more points, particularly around those callers that have a delay or a wait for an ambulance. We do have a process in our control room where we will ring them back, and the control room will get an alert to say, this patient's been waiting now for 59 minutes. We won't let them wait any more than an hour before a phone call from a clinician to check in. Has anything changed? Is your condition deteriorating? So we don't just leave patients to wait. If there is a long delay, they're not just left in that particular case. We do also advise patients that if their condition does deteriorate, they should ring us back straight away. And I think the only other thing I wanted to just mention, if I may, Chair, was around cardiac arrest. Councillor Hill quite rightly pointed out that I think it is only 4 minutes when the brain begins to get starved of oxygen, that's quite crucial there. And for me, it highlights the importance of CPR, or cardiopulmonary resuscitation. Anyone can do it. It's very easy to get yourself trained on all of that. We do that training, but you don't have to come to us. There are other service providers that do that. And we do have an ambulance, we do have a charitable arm of our service which we are now looking to grow and expand again to support the community bringing defibrillators into their communities as well. We will, whenever a member of the public calls with a patient who's in need of defibrillation, we have a system that can show where the nearest defibrillator is. And if that defibrillator is within 500 metres of the patient location, we will then ask the caller to go and get it. Any longer than that, and we consider the period of time away from that patient to be too long, the patient better off having somebody next to them who may be able to do CPR or whatever else is needed. So obviously 500 metres is a 1,000 metre round trip journey. That's 2/3 of a mile. That's quite a distance. So the more defibrillators we can have in the community, the better it is for the community themselves. So that's something that we would always want to advocate and support.
Before we go on, we have a working group here who are, along with any NIAS, we are looking into the defibrillator question because we think they're like mushrooms. But nobody seems to know about the maintenance, backup, and the finding the funds to renew the battery and all that. That's ongoing, but we're all very interested in that. And lucky Les there, he's got about 25 in seating. 29 now, is it?
We'll just say 22.
He's got enough defibrillators to satisfy his area. But what we're trying to do is find the black spots, and it's ongoing work, but it'll come out in time. But can you take us through?
I can do. I've got this here in front of me now, Chair. Thank you, Claire.
Which page are we looking at? Or which area?
I'm happy to look at any page. Claire got the tab open for Northumberland, so we
I
can
would
look
do
there
that.
if you
We'll
like.
do that because it's such a deprived area.
So what we've done here is produce the data by month for the most recent data for the last 12 months. I appreciate we're now into April, but when I submitted this to Chris, I think we were in early March. So the most recent data available to us then was January. But I wanted to show by month a breakdown over the last 12 months so that you're able to see any changes across the whole of the year rather than just having a look at one particular year. But if I look at February of 2023, you can see there that in Northumberland, the number of incidents that were Category 1 attended by an ambulance were 40. And then the number of C2 incidents attended by an ambulance was 364. And the number of C3 incidents was 169, and you're getting the picture here, 24 for C4 incidents. Oh, wonderful. So those are the first 5 columns there. Then we come on to the response times. So the total response time for C1 in that month was 5 minutes, 28 seconds. No, hold on. No, it's not, is it?
5 hours. It's the total response time, but it's your C1.
Yeah.
Mean was 8 minutes.
Yeah, I beg, thank you, Claire. You're better off doing this than I. Yes, so we're counting days, hours, minutes, and seconds. So where we just got 3 numbers there. So the total response time there is 5 days. I'm not quite sure why I included that because that doesn't mean anything to you. So apologies for that. And you can see there similarly the total responses for C2. What you'd be more interested in then is the C1 mean. So this is the average response time to those 40 cases of C1, which was 8 minutes and 12 to all of those cases. The average response time to the C2 was 26 minutes and 47 seconds. Then the response time to get to 90% of the C1 cases was 15 minutes and 57 seconds. And you've got to remember here the target for that C190 is 15 minutes. And then to get to 90% of C2 cases, we got to 90% of those in 55 minutes and 4 seconds. The standard there is 18 minutes, as I said earlier. To get to 90% of the C3 cases was 1 hour 17. And then to get to 90% of C4 cases was 1 hour 49. And then the numbers at the bottom, the total numbers at the bottom in the bold, as it were, give you that figure for the year for that particular area. So that you can see there that the average response time to C1 calls in Northumberland over those 12-month periods was 10 minutes 13 seconds. The average response time for the C2 was 30 minutes and 17, and so on.
Thank you.
So I would, we've obviously given you the total response time and added that up. So you can see there that the total response time comes to 10 days, 7 hours, 46 minutes, 33 seconds. I'm not quite sure why I left that in, because I can see how that might be confusing, but you can see the totality there.
Thank you. I think that will help us in the future when we look at these. Right, Councillor Hardy.
Yeah, just on the Northumberland, just for a little bit of clarification here. I represent Northern Ireland.
Yep, Tom.
So I represent Northern Irelandshire, so it's a very rural ward which covers places like Lowick, Norham, Cornhill. How far do you cover under Northumberland? Is that Wooler? Would that be Belford? Sea Houses?
It's
Just for an overview.
I'm told it's the LAC area, local area council.
We were provided postcodes by your authority, and we then drew up this data based upon those postcodes. So, yeah.
Sorry, Councillor Hardy, it's based on the local area council.
Colin, you're getting an answer here.
Yeah. So it's based on the local area councils, which is where we've got North and we've got Cramlington, Blythe, Morpeth. It's done by the 5 LACs. So whatever fits within that LAC, that's what the data is based on.
Thank you. That makes it even more impressive for the response times. Thank you.
So that goes as a tick in the box on the right side. Right. Councillor Hunter.
Yes, it is. We've been on this committee for a few years, and we've always brought up about the response times. This table is very good, and it actually shows the 2 spikes that we have, the winter time, but also the summer time when we've got the tourists, which puts more pressure on your service. So the times that you're actually coming out in, appreciate C4, it is a long wait, but they're the people that can wait a bit longer without being cruel to them. But no, as I say, it's nice to see the detail in this, and the times is not as bad as what some residents make them out to be. Thank you.
Yes. Right. Anybody else before we... Yes?
I just think, well, the follow on from Isabel there was, we did a visit a few years ago to the ambulance station, and to see the response times then in the north and all the rural areas was horrific. And you've come a long, long way since then. I must be going back about 5, 6 years ago. And I think you've come a long, long way since then to the rural areas, the response time, so it's well done. You're getting there.
Right.
Chair, I don't know if I can just come in there as well. I don't think what we do report on as well is how many patients are seen in their own home now because of the skill level of paramedics. So I'm obviously responsible for the North Division, and there's 27% of the patients that we respond to are actually left at home, whereas they're actually referred to other services or they're cared for at home. There's 50% of them patients that are transported to ED because they need that primary care. But there's also a number of them, about 17%, that then go to urgent treatment centres. So, other places within the community and using the community services, so they don't have to travel further afield either. And I think that's based on, obviously, what skill set is improving. of the paramedics get more training.
Councillor Hill, finally.
Yeah, just to say, I agree with the overall message, which is there's been improvement and there's improvement in the presentation of the data. But I don't want, anyone watching this or reading any report in the press, if we do know people, so if somebody has had a loved one who's had a long wait, and any way that we're complacent, and the nature of it, if only one person waits an hour and a half and dies, then it's really serious. So we don't want to be complacent. One thing I would just add in terms of anecdotally, you do get quite often people say they rang up for an ambulance, and I suspect these are more category 2, but have been told you're too long to wait, you best jump in the car. I don't know if you've got any sort of comments on that, but I do hear that quite a lot. People having to put the patients in there. And obviously that doesn't show up in the data either. If somebody's just having to. And that's, so somebody calls up, if it is for whatever reason, and it's particularly if it's category 2, they are advised about the likely wait. Is that, the operator, will they tell them how long they're likely to wait?
Yeah, so for a category 3 call, so sometimes if you're in a period where the clinician decides that that patient's safe to be transported, then rather than wait for an ambulance, then we would ask them if the patient feels, happy, or the relative, they've got a car on the drive, they're happy to transport them down to an A&E because that's where they best need to be seen. They don't necessarily have to wait. But also in a category 2 call, we will, if we are in extremis, so that's when we are in high escalation levels and we've got a lot of patients waiting, then we will offer to the person who's ringing, if there is a relative there, we would offer them what the time scale is, because sometimes that would make the difference between them wanting to transport themselves. I know for me personally, I am a paramedic by trade. If I'm sitting 5 minutes away from an A&E, for example, I live round the corner from the Queen Elizabeth and Gateshead, or I'm going to wait an hour for an ambulance and I can safely get somebody a car, then actually would it not be more appropriate for me to get them in the car and take them? So I think it's just given them people that measure around actually how long you do need to wait. And a lot of people sometimes, they don't call upon their relative first in the first instance. They might ring us as the first instance. It's just seeing if there's anybody else available who can transport them to get them there. But that's really when we're in extremis and we've got a number of jobs waiting on the stack.
I think, if all of us go back to our youth, some of us go back a lot further than others, but anyway, there was a doctor. You rang the doctor, and the doctor would come out or whatever. That doesn't happen now, I don't believe. Or, and the options now are you've got A&E, you've got the phone line to ring, for help, and you've even got walk-in centres now. So, I think the service has got to be a lot better from when we were a certain age. So, may it long continue to improve.
No.
Well, Kathy, it is improving. I'm back to it. It's an election year, but we'll not dwell.
This is going to be getting to be politics now.
I'm not playing. I'm just saying.
We are disagreeing. So sorry, but you're going to get into politics here, and I'm sorry, I won't go there.
Right.
But I'll disagree with you.
I'd like to thank you both for coming along. Again, very interesting, very useful. It always is. And we'll see you probably in a year or whatever the annual thing is. And when
maybe organise something for that after the local elections if people are interested. I'll liaise with Chris about that.
That's next year, by the way. That's a general one this year.
Thank you for your time and help. Thank you.
Well said, Josephine.
Good job. I'm like Les. I've got hearing problems. So. Right. Forward plan, Chris.
Thanks, Chair. There's nothing on the Cabinet forward plan of decisions that have been taken or are due to be taken that would be relevant for this committee. Although the forward plan is probably a little bit out of date now because of when it was last done, but I still don't think there's anything to come. But as always, if there's anything that members want to look at, just to let me know. And then the work programme is there to note. It just mentions the agenda for the next meeting on the 7th of May, which will be the CNTW quality accounts, and Newcastle Hospital's quality accounts. And I will circulate the 24-25 work programme later on today, so members can see what we've got planned for the next 12 months. But as I say, if there's anything that members want added to the work programme, just let either myself or the chair know.
Okay, I have no urgent business, so we'll close the meeting. Thank you for your attendance, and those of us got to sit around till 4 o'clock till